Let me discuss one of my patients who recently visited me with a history of knee pain for the past 1 month. This lady typically got the pain when she went for some pilgrimage trip to one of the temples in South India. The pain was initially mild, and then as she walked more, the pain picked up in intensity. And once she came back, she applied some oil and then gave some hot pack and thought that the pain would be all right, but eventually the pain got worse. Since the pain did not go away, she met an orthopedician, and then the orthopedician subjected her for an X-ray. The X-ray looked like this. By looking at the X-ray, the orthopedician told that it is a grade 2 type of arthritis, and then she may even need a surgery after a few years or so. So he gave her some medications and then some gels as usual. The pain was okay as long as the medicines was taken, but the pain eventually came back as the medicine effect came down. And then she thought that she must meet a physiotherapist. Through one of her relatives, she got to know me, and then she came to me. I did a detailed evaluation. I found that the range of motion was normal. Both the active and the passive range of motion was full, but at the end range of flexion, when I was giving a overpressure, the patient was having some tiny bit of pain in the middle aspect of the knee joint. When I checked the strength was okay. I found some mild warmth over the middle joint space compared to the other side, as well as I found some mild swelling in the middle joint space, which is of course visible only for the trained eyes because it's a very subtle swelling. On palpation, the pain was exactly where I was keeping my thumb. The pain was exactly over the middle joint space. And then we thought that, okay, the X-ray is not really correlating with the locality of the pain what the patient has, because the X-ray, if you see, it is mostly having a lateral joint space narrowing. You can say confidently that the patient is having a lateral compartmental arthritis more than the middle compartmental narrowing. If you see, this is somewhat better than this. Of course, this is okay for a 56-year-old lady, but when you see the compartment in comparison, definitely the patient should have the pain over the lateral aspect of the knee joint than the middle aspect. But surprisingly, the patient is having pain only in the middle joint space where I kept my thumb over here. She never complained any pain over the lateral aspect of the knee joint. The intent of my talk today is to make you understand why sometimes X-ray can be misleading. The pain can be coming from somewhere else, whereas X-ray will be showing something else. And that's why you have to do a detailed clinical examination, and then you see whether the examination findings are correlating with the X-ray findings. Because the pain is exactly over the middle joint space, because there's mild swelling as well as warmth, as well as tenderness on pinpoint pressure, we diagnosed this patient as having mild middle meniscus sprain. I'm not exactly grading what is the type of meniscal tear here. I can only suspect that it is a mild to moderate type of thing, because if it is a severe tear, then the patient would not be able to walk and there will be some major movement loss or severe disability that this patient was not having. This patient was having pain in the middle joint space, swelling and warmth in the joint line, passive enraged overpressure pain, and walking worsening the pain, whereas the rest is relieving the pain. My patient was having the first few things here. My patient was not having the joint lock and release or bouncy end feel. If there is a bouncy end feel and then joint lock and release, then you can diagnose this patient with a middle meniscal tear with a reasonable confidence. But here the lock and then release was not there in my patients, as well as when I checked the range, the bouncy end feel was not there. But there are other clinical clusters which can be used to diagnose it as a middle meniscal strain. The pinpoint tenderness, warmth, and pain at the end is overpressure, and walking is worsening the pain, and rest is relieving the pain. So all these clusters are indicative of the patient is having a mild medial meniscal tear. Let me analyze this X-ray. This is the femur. This is the tibia. If you see the tibia and the femur, their alignment itself is not correct. The femoral condyle is not exactly sitting in the tibial condyle. There is some amount of space over here. This is perhaps because of the tibia vara tendency over here. Ideally, when there's a genu varum tendency, there should be a middle joint space narrowing. But in this case, the patient is not having a middle joint space narrowing, rather she's having a lateral joint space narrowing. So that's the reason why sometimes we tend to get perplexed in genu varum why it is a lateral joint narrowing. It is not always a rule that people with genu varum will have a middle joint space reduction, and people with genu valgum will have a lateral joint space reduction. It is not the case, because we need to also look at the anatomical axis of the tibia and the anatomical axis of the femur, and whether they have coxa vara and coxa valga. All will decide how the line of gravity is passing, that will decide whether the patient will be having medial joint compartmental space reduction or lateral joint compartmental space reduction. Accordingly, the patient symptom will be varying. In this case, the patient is having a reduction in the joint space in the lateral aspect, but fortunately, the patient is not having any symptoms yet. This patient is having a mild sprain over the medial meniscus, which is perhaps because of her recent pilgrimage trip. In South India, the pilgrimage means they have to go to many temples, and every temple will be having easily about 50 to 75 steps. Okay, so that was an unaccustomed stress to the knee joint for which this body type was not ready for. This patient is also in the heavier side, so obviously the body weight also would have played a role here. So the diagnosis is acute meniscal sprain, which might go away in a month or so with appropriate intervention, which includes rest, load modification, and maybe if needed some bracing and joint deloading exercises and so on, which is what we are currently doing now. But if you strictly go by the X-ray, you may end up diagnosing this patient as having lateral compartmental arthritis, completely ignoring the current clinical finding of the patient. Thereby, your clinical diagnosis will go wrong. X-ray is often useful, but X-ray alone may not be telling the entire story. X-ray is definitely useful in the initial stages because we don't definitely send all our patients for MRI. Initially, we just check the X-ray and see what is the tibiofemoral angle, what is the Q angle, what is the patellofemoral alignment, what is the position of the patella, and how is the joint compartmental space in the medial compartment and the lateral compartment. Is there a tibia vera? These are some of the basic things that we see in the X-ray. But obviously, X-ray is good for ruling out the big fractures or dislocations, but definitely we cannot see soft tissue injuries in the X-ray. So in such cases, if you are very keen on looking into the meniscus and having more and more details of the soft tissues like ACL and PCL, then you need to refer for MRI. To diagnose the degenerative arthritis, often X-ray is sufficient. With the X-ray, you can say whether it's a grade 1 or a grade 2 or grade 3 arthritis, and the tibia vera and tibia valga you can analyze. You can also see the line of gravity and so on. But unfortunately, you cannot see the X-ray and find the source of pain because the source of pain is entirely different. X-ray is only going to show the anatomy, whereas pain is physiology. Physiology is more of like functional, right? So you need to clinically analyze the patient to check where the pain is coming from, because some pain can be mechanical pain, which are driven by movements. Some pains are inflammatory, which are driven by the autoimmune factors, inflammatory parameters. So sometimes it will be mixed also. So it's quite complex. That's why the physiotherapist must do a clinical examination in a detailed manner and then see the X-ray or MRI, see whether the findings are correlating. Then you decide whether to consider the findings in the X-ray or not. Based on that, you give the exercises or load management strategies to the patient so that you put the patient into the right path. Straight away giving the medicines, because no medicine can cure OA, no medicine can prevent the future TKR. So medicines are only for temporary respite for the pain. But in the long run, the patient has to be educated about all the load management factors and then inflammatory factors and then the load factor and exercise factors in order to bring a comprehensive improvement to the patient, which is the job of physiotherapists, because they are the one who spend a lot of time with the patient than the other healthcare providers. So in the nutshell, X-ray is useful for knee arthritis, but X-ray alone will not tell the entire story. Clinical examination and the clinical diagnosis is always the king, especially for cold orthopedics. I trust you learned something today. Thank you.